much awaited Dr. Vidya Acharya Oration on kidney transplantation in DKD. May I invite the speaker, Dr. Georgie Abraham. I take this opportunity to invite the chairpersons for the oration, Dr. Sunil Shroff, Dr. Maman John, and Dr. Noble Gracious. Over to the chairpersons.
A very good morning to all of you. It's a great honor to sit and chair Professor Vidya Acharya's oration. Am I audible? Yeah, I thought so. So, I'm sure you all know about Professor Vidya Acharya, but let me give you a brief introduction to the youngsters. She was called the mother of nephrology. She was a very kind soul, very benevolent, almost pious. She was born in 1938. She did her, undergraduation from SG State Medical College in Bombay in 1959, and went on to do her MD in 1965. She joined as an assistant lecturer first at KM Hospital and established a unit of nephrology at that time called artificial kidney. And I think she established a dialysis program. She was the first to establish a dialysis program in that institute. She won many prizes. She was very dedicated to her patients. And she was also honored at Hong Kong during the World Congress for her contribution to nephrology. So, she had a great innings. She contributed a lot to nephrology. And, unfortunately, she passed due to a sudden illness in 2014, in May. And she established the National Kidney Foundation in Mumbai as well to take care of education of nurses, dialysis technicians, and so on. So greatly honored to chair her oration. And I would want Dr. Mayman to say a little bit about Dr. Georgie Abraham, our orator. And we have Dr. Noble Gracious with us, and perhaps you can wind up at the end. Yeah. Thank you.
Good morning once again. It's my proud privilege to introduce one of the senior-most nephrologists in the country, Dr. Georgie Abraham, who doesn't need much introduction to this forum. He's currently with the MGM Healthcare. Dr. Sunil Shroff had said Dr. Vidya Acharya was the mother of nephrology. So I can call him as the father of CAPD, and one of the topmost nephrologists in the country is currently with MGM Hospital. Over to you, Dr. Georgie, for your talk.
Yeah. Good morning, and respected chairperson, Professor Sunil Shroff, the president of the Indian Society of Transplantation, and Dr. Maman John and Dr. Noble. It's a great pleasure and honor for me to give you the Vidya Acharya oration. In 2015, for the Indian Society of Nephrology annual meeting, I gave the Vidya Acharya oration at Calcutta. So this is a great honor for me and distinguished colleagues. I will take you through our experience and the experience abroad regarding transplantation in diabetic kidney disease. Tribute to Professor Dr. Vidya Acharya. I have known her for over 3 decades. She is the first lady nephrologist in India, revered and loved by all, outstanding passion for research, education, patient care, and collegiality. We have memorable anecdotes of her because we traveled together nearly a decade ago to Pakistan for the Pakistan Society of Nephrology meeting at Faisalabad. And on the return, we had some very interesting, but I don't have time to talk about that. And her principle was Parupakaram Artham Idam Shariram. So the outline of my talk is risk and kidney transplantation, rejection in diabetic kidney disease, case studies, donor and recipient with DKD, immunosuppression and survival. So the goals of transplantation are no acute rejection, no adverse drug effects, 100% patient survival, 100% graft survival. Is it really possible? So this cartoon shows the challenges in transplantation. You have medical challenges, especially diabetics, and those with obesity, and also those with blood vessel peripheral vascular disease. And then you have immunological challenges. It is sensitized patient. And then psychological challenges, because they haven't made up their mind to go for a transplant, and some of them may be in severe depression, and should we take them for transplant? And so the others are so it's shown on the right side, the sensitized patient, immunological risk, subclinical rejections, chronic allograft rejection. So monitoring of anti-HLA antibodies, MICA antibodies, Luminex beads with absorbed single HLA antigen, and what are the approaches to tolerance. So the most important medical issue with transplantation is diabetes mellitus and multiple comorbidities in those recipients. So they are vulnerable, the diabetics are vulnerable to infection, we know that, and as a result, we need to be very careful in immunosuppression. Immunosuppression is defined as the prevention of interference with the development of normal immunologic response. The immune system also recognizes an allograft as a foreign body and will mount vigorous immune response against the allograft in an attempt to destroy it. Immunosuppression with medication is necessary to prevent destruction of the graft by the immune system of the recipient. So the risk factors for acute rejection, the most important is the number of human leukocyte antigen mismatches A. So rejection is a process shown by the cartoon here. Recognition and immune response to the allograft by the recipient's immune system, resulting in allograft destruction, starts with the placement of the allograft. Donor antigens enter the systemic circulation and lymphatic system to access the secondary lymphoid system, where naive T cells are activated. Donor cells leave the allograft and the recipient cells enter the allograft, result in direct and indirect allorecognition as shown in the cartoon on the right side. So goals of induction are depletion of lymphocytes. Thymoglobulin depletes them 83 to 92% with a single dose. Time to induction is minutes to hours to days. Duration of lymphopenia, peripheral lymphocytes and lymphocyte subsets are very low after thymoglobulin induction. So the advantages of induction immunosuppression are: provide strong immunosuppression initially when immune response is the most vigorous, easier to prevent than to treat rejection. Rejection may exacerbate reperfusion injury. Now, these are the drugs which are used for induction immunosuppression. Induction agent, if you look at in United States from 2004 to 2014, you can see that T-cell depleting agents are the most common, from 40% to over 60%, whereas IL-2 receptor antagonists are becoming less often used, and no induction immunosuppression is also very less. And the most common CNIs used are tacrolimus and cyclosporin. We all know that tacrolimus is a diabetic-induced agent. And then you have antimetabolites, mycophenolate mofetil, and azothioprine is less commonly used or almost completely have waned. And then mTOR inhibitors and they are also used, but their use is also much less now at transplant and 1 year. And steroids, the problem is diabetes mellitus. All transplant and 1 year post-transplant, it is shown here, they really merge together. So single dose thymoglobulin, our experience, acute rejection was 7%. Now, we talked about HLA. What is MHC? Missed histocompatibility. Chromosome 6 genes for HLA molecules, class 1 and class 2, A and B express all nucleated cells, class 1, and class 2 are found on B cells, dendritic cells, and macrophages. Antigen-presenting cells are the dendritic cells, macrophages, and B cells display peptide fragment, and antigen-presenting cells express co-stimulatory molecules to activate T cells. Now, a cross-match is an absolute must. It is perilous to ignore a positive cross-match, and it is a contraindication. There are different types of cross-matches. Now, let's move. Algorithm for assessment of living kidney donor candidates with impaired fasting glucose. Donor assessment of risk for diabetes mellitus for the donor, BMI over 25 with a major risk factor, history of gestational diabetes, history of positive oral glucose tolerance test in the past, features of metabolic syndrome, first-degree family members with diabetes. the prevalence of diabetes is 1 in 3 diabetes develop diabetic kidney disease and progress to end-stage renal failure. Now, if it is present, any of this is present, you go to perform a oral GTT. If it is less than 140, assess risk, maybe a suitable donor, consider circulating and calculating donor diabetes mellitus risk, age and ethnicity. And if after the GTT, if it is 140 to 190 milligram, IGT, impaired glucose tolerance, likely not a suitable donor, calculate diabetes mellitus risk. So if the blood sugar is over 200 milligram per deciliter, diabetes mellitus not a suitable donor. And when it is absent, you may look at the fasting blood sugar, the fasting blood sugar and the fasting blood sugar. And if the fasting blood sugar is high, you don't take them as a donor as per the risk. And if it is normal, you can take them as a donor. So since diabetes affects nearly 97 million people in India and an equal number with impaired glucose tolerance or blood sugar 100 to 126. So kidney replacement therapy in diabetic kidney disease is dialysis, either peritoneal or hemo, kidney transplant from a living or deceased donor, pancreas transplant after kidney transplantation, simultaneous pancreas kidney transplantation. All diabetics should be thoroughly evaluated for cardiovascular disease, infections, malignancy, and peripheral vascular disease, and psychological assessment. So this is our examples of using live kidney transplant between diabetic mother and non-diabetic daughter. There were nobody in the family, and there was a good HLA match. And this is the mother after, in 2013, the transplant was done. The mother donor is now 67 years old, type 2 diabetes mellitus. The weight has gone down from 63 to 59 kilograms. And currently, her hemoglobin is 13.5. The most important is urine albumin creatinine ratio, 27 microgram per milligram of creatinine, and serum creatinine is 0.9, and blood pressure 120/90 on antihypertensive therapy. And the recipient is doing very well. She was the mother of 2 children and on triple immunosuppression. This is another one, a diabetic father-in-law to daughter-in-law, donor 67 male, and this was also transplanted in 2012. His current investigations, hemoglobin A1C is quite high, and he needs better control. His serum creatinine is 1 milligram, ACR is 10 microgram per milligram of creatinine, and the recipient is doing very well, and his blood pressure is 120/80. Now, let me tell you, recently we had to take a mother diabetic for a diabetic son, and this is the recipient detail, 31 years old, male, diabetic kidney disease, B positive, 2 children, non-smoker, hypertension, BMI 24.7, maintenance hemodialysis since February 2021, anti-HPS antibody 500 international units, hemoglobin A1C 5.2, ECG normal, echo showed global hypokinesia with an EF of 40, coronary angiogram showed normal epicardial coronaries. The mother 48 years, type 2 diabetes, 18 years on oral hypoglycemic agents and insulin, and she was found to be hepatitis surface antigen positive. And I had an infectious disease consult. The viral DNA load was undetected, but the son had an anti-HPS antibody as 500. So she is on entecavir, and we proceeded with the transplant. This is the angiogram showing the mother's donor's kidney, and this is the GFR. The left kidney was harvested and transplanted. So this was the HLA typing. I alluded to about the HLA typing. Look, everything green is compatible. See, they had a very good HLA match between the mother and the son, the recipient. And 6 post-operative days, BP was 120/70, creatinine 1.34, fasting blood sugar, immunosuppressive medication is 40 milligram prednisolone, tacrolimus 4 milligram, and MMF 1 gram BID. And he is doing well now. Now, this is one of my longest living post-transplant diabetic recipient. 21 years after transplant, a businessman from Kerala. 73 now, diabetic with retinopathy, autonomic neuropathy, and nephropathy. When he came to us, underwent live-related kidney transplant on 35/2000, no rejection episode. Currently, serum creatinine is 1.3, urine analysis is normal, it is mandatory that anterior segment and posterior segment of the eye should be examined with dilated fundoscopy because he had multiple bleeds in his retina. Immunosuppression, mycophenolate mofetil, cyclosporin, prednisolone, and BP is 130/70 on ARB, calcium channel blockers, and insulin. Now, contraindications for transplant are malignancy, active infection, psychiatric disease, alcohol dependence, drug dependence, cardiovascular comorbidities, and morbid obesity. So, patient survival in diabetic kidney disease and non-diabetic kidney disease. This is Vidya, who has written the Handbook of Kidney Transplantation with us. A study done from 2008 to 2013, the 5-year survival of patient rate in diabetic and non-diabetic group was 96.6 and 98.7% respectively. Simultaneous pancreas kidney transplantation, SPK, United Network for Organ Sharing, UNOS, has defined the following criteria for SPK in type 2 diabetic patients: an insulin on insulin therapy and C-peptide less than 2 nanograms per ml, and insulin therapy with C-peptide over 2 nanograms per ml if the BMI is less than 28.5. Now, our experience, those who are below the age of 40 and above the age of 40 to 60 and above the age of 60, and we had diabetic patients. I'll show you the data. This was published by my colleague Ashik Ali. Coronary artery disease was statistically significant more in the older age group. LDL was not statistically significant. Smoking was not statistically significant. And diabetes was not statistically significant. And hypertension was not. BMI was statistically significant. So this was the immunosuppressive regimen we used: tacrolimus, cyclosporin, earlier group, MMF, prednisolone. Induction agents were basiliximab, daclizumab, thymoglobin, and no induction, 25.4 to 27.3 at reduced dosage, not at the dosage which was recommended in developed countries. And potential predictors of outcome: pre-transplant history of the recipient are coronary artery disease, peripheral vascular disease, GI liver disease, respiratory, diabetes mellitus, cancer, tobacco use, time on waiting list, donor factors, and donor factors as disease versus living, age of the donor, and delayed graft function. So I have shown you some examples of donors being diabetic. The largest data is published from SUT in Pakistan. Till 2018, they had 58 donors with diabetes who are donated to their relatives, close relative. And this is our death-censored graft survival between 40 to 60 years in the blue and above 60 years in the pink. And you can see that at 5 years it was not statistically significant. And when you move on, the patient survival also, it was not statistically significant. And when you look at this, in the 40 to 60 age group, 45.3% were diabetic, and in the above 60 group, 59% were diabetic, not statistically significant. So we are transplanting a lot of young people also in the middle age with diabetes and also elderly age group. And this shows that they do reasonably well unless they die of a myocardial infarction or massive sepsis. So this is from the downloaded. The diabetic donors, I'll just show you that this is a very busy slide. Kidney donors with diabetes, renal biopsy finding at the time of transplantation, and they're significant. So you look at the age of the group here, shown that majority of them 37 to as high as 71 years of age. Race is shown there, and the BMI is shown there, gender is shown there, hypertension and diabetes status, type of dialysis of the recipient is shown. And I want you to show that they take double immunosuppression or triple immunosuppression, and the protein at follow-up was protein creatinine ratio varied from anywhere between very little to high. Last two slides. So kidney donors with diabetes, renal biopsy findings at time of transplantation and their significance. This shows the basement membrane thickness is measured here. You can see that 596 and 470, and it shows mild mesangial sclerosis as shown here and mild increase in cellularity. So can we take these kidneys and transplant? I believe that definitely yes. So follow-up of diabetic kidney transplant recipients, albumin-creatinine ratio has limitations because of native kidney proteinuria. As shown in the previous slide, PCR may be helpful in the spot urine sample. Hemoglobin A1C should be maintained less than 6.5. Better than that would be time averaged glucose concentration in 24 hours, 80 to 170 milligram per DL. Insulin DPP-4 inhibitors, metformin and SGLT2 inhibitors can be used. I want to caution you on GLP-1. I have patients who had life-threatening pancreatitis, which was not known, and also transplant patients who were using GLP-1 analog, liraglutide with gallbladder stone, which we removed last week. So I inquired with the pharmaceutical company in India. They refused to give me any data on the side effects, life-threatening the side effects of GLP-1 analog used. And it is sad that, the respectable pharmaceutical company doesn't give you data on the complications which the patients face. And monitor kidney function and EGFR with cystatin and cystatin creatinine combination. The BP control should be less than 130/80 with the use of calcium channel block, CCBs, diuretics, ARB, and centrally acting drug. So rescue therapy with monoclonal antibody for diabetic kidney disease patient or with COVID, indication mild to moderate COVID in adults and pediatric population, laboratory confirmed SARS-CoV-2 infection, high risk of severe COVID-19, no oxygen requirement, dosage of casirivimab and imdevimab is approved at combined dose of 1200 milligram administered IV infusion or subcutaneous tube. When to start? Should be given together as soon as possible after positive SARS-CoV-2 results of direct viral testing and within 10 days of the symptoms of onset. So in conclusion, kidney transplantation is the best RRT for DKD. The DKD recipient should be carefully chosen, avoiding malignancy, ongoing infection, cardiovascular risk. Immunosuppression should be carefully delivered to avoid infections, malignancy and metabolic complications, surveillance for diabetic control, CKD stages, diet, infection, prophylaxis, recurrence, especially in the COVID time. I have given COVID vaccination to all my transplant recipients. Drug monitoring and onset of new cardiovascular disease, as Mahatma Gandhi said, be the change you want to see in the world, and thank you for your kind attention.
Thank you, Dr. Georgie, for your excellent presentation on diabetic kidney disease. As transplant nephrologists, we all face the problem of having recipients with diabetes, and also Georgie has actually taken even diabetic kidney dose. It was a surprise for me, and it's shown good data on diabetic kidney diabetes patient as a donor, because we have a very particular prevalent diabetic population in our part of India. And I think we should also explore the possibility of selecting donor with diabetes, because of we know that donor within the family is very restricted in our population. And I will also recommend all our junior colleagues and postgraduates to grab the book which Dr. Georgie has authored, which is Handbook on Clinical Transplantation. Yeah. We all have participated in contributing to the chapters. This is actually a very book which is relevant to our population and to our circumstances. All evaluation, all are suited for our country, and it's specifically designed for developing nations. So I would recommend all our postgraduates to take this book written by Dr. Georgie. Thank you, Dr. Georgie. Any questions from the audience?
I would also want to add that Dr. Georgie Abraham has written his autobiography, just recently published. So have a copy of that as well.
Yeah.
It is with a lot of passion. He has written those chapters, a lot of stories he said about his patients. So do some of you in the audience can take it from I think you have left a few books there. Thank you.